Good morning, everyone. On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meet. In the series of Rheumatology Clinical Pulse, today we will discuss lupus nephritis and anti-phospholipid syndrome. We have two eminent speakers with us. Professor Vijay Kher sir, he is nephrologist, and Professor Ramnath Misra sir. Professor Vijay Kher will discuss management issues of lupus nephritis, while Professor Misra will discuss anti-phospholipid antibody syndrome practice steps. I request all the participants and audience to send their queries in chat box. We will discuss with Professor Vijay Kher and Professor Misra after the two lectures. Professor Vijay Kher is Chairman, Division of Nephrology and Transplant Medicine at Epitome Kidney Urology Institute and Science Hospital. He has established academic and clinical departments of nephrology at Sher-e-Kashmir Institute of Medical Sciences in Srinagar, then Sanjay Gandhi Postgraduate Institute, Lucknow, Apollo Hospitals, New Delhi, Fortis Group of Hospitals, NCR, New Delhi, and Medanta, the Medicity, Gurgaon, during the last 40 years, after his return from stint at Henry Ford Hospital, Detroit, and University of Cincinnati Medical Center, Cincinnati, Ohio, USA. His primary area of interest are kidney transplantation, progression of renal disease, acute kidney injury, and glomerulonephritis. His group is pioneer in the world for the development of robotic kidney transplantation, a novel surgical technique to provide advantages of minimally invasive surgery in this high-risk group. He has been past president of Indian Society of Nephrology, member of KidGo Transplant Recipient Evaluation Work Group, regional research coordinator, International Society of Nephrology, South Asia region. He has been awarded Fellowship of National Academy of Medical Sciences, India, Royal College of Physicians, Edinburgh, and Indian Society of Nephrology and orations of various scientific societies. He has published 240 papers in peer-reviewed journals, 43 book chapters, and he has edited 11 books. The second speaker for today's meeting is Professor Ramnath Misra, Professor and Head at Department of Clinical Immunology and Rheumatology and Dean at Kalinga Institute of Medical Sciences, Bhubaneswar. Formerly, he was Professor and Head at Department of Clinical Immunology and Rheumatology and Dean at SGPGI, Lucknow. In fact, he started Department of Clinical Immunology at SGPGI, Lucknow, and he has trained more than 50 DM residents in immunology. He is member of Scientific Advisory, National Institute of Immunohematology, ICMR, Mumbai, and Regional Medical Research Center, Bhubaneswar. He has received APLAR Masters in 2021, Fellow of the Indian Academy of Medical Sciences 2019, SR Naik Research Award by SGPGI 2017, MN Pasi Award by IRA in 2013, Samantha Chandrasekhar Award by Odisha Vigyan Academy 2010, FRCP London 2009, and ICMR Talent Search Fellow in 1979. He has published around 225 research papers, and his total citations are around 8,106. H index is 44, and he was past president of Indian Rheumatology Association. With this, I request Professor Vijay Kher sir to start discussion on lupus nephritis. He will teach us on lupus nephritis.
Thank you. Thank you, Dr. Banwari, for that wonderful introduction. And good morning, ladies and gentlemen. So, sorry for that glitch. And I think, Dr. Banwari, thank you very much for inviting me. And it's great to be speaking to you. I think we got invited 2014 in Jaipur, and that was a physical meeting. And it's a pleasure to do this visual or audiovisual. So the topic that was given to me was lupus nephritis. So I have made it into something new, something old. As most of you know, that renal disease in SLE carries high morbidity and mortality, and that's the reason you and I am talking about it today. Prior to corticosteroids, the 5-year patient survival in lupus nephritis was less than 17%. However, with the introduction of steroids, it improved to 55%. And Victor Pollack, who published this data, has been my mentor at the University of Cincinnati, where I worked with him for about 2 years. With the introduction of cyclophosphamide after the NIH trials, the survival in lupus nephritis improved to more than 80%. And you and I see large number of lupus patients survive with these therapies for long periods of time. However, despite the current standard of treatment, it's only about 1/3 of patients with lupus nephritis who develop complete response, and more than 30% of patients will develop end-stage kidney disease. And with the development of end-stage kidney disease, there is decrease in the survival in these patients. Even in mild disease with lupus, a person who had just early stages of lupus disease decreases the lifespan by 15 years or so. Those who have moderate to severe renal damage and renal disease decrease their lifespan by 23 years. And those who develop end-stage kidney disease and lupus nephritis have a 26-fold increase in the mortality in these patients. So that's why lupus nephritis still carries a poor prognosis in these patients. For diagnosing lupus nephritis, we usually do a kidney biopsy. And I feel that kidney biopsy in every patient of lupus nephritis, even with minimal urinary abnormalities, since there is so much of lack of correlation between clinical signs and histology, you may have very minimal urinary signs and clinical symptoms, and you do a biopsy and you may have class 4 disease, or you may have somebody who has very high number of clinical symptoms or signs suggestive of lupus with urinary abnormalities. You may have minimal or moderate disease on the biopsy. And this is one such study where people who were induced with first episode of lupus nephritis, complete clinical remission, those patients, 33% when they looked at histology, had persistent activity. And large number of patients who had complete biological remission, histological remission, still had a lot of clinical activity. So there is a poor correlation between histology and clinical symptoms and signs in patients of lupus nephritis. So most of these patients need to be biopsied to find out where exactly. And then there is also transition from one stage to another stage that has been also noticed in the lifespan of a patient with lupus nephritis. This is an algorithm which was given in 2015 looking at biopsy, but there is a greater tendency these days, even when patients have achieved remission after, say, 6 months or 1 year of the induction therapy, many people are advising and suggesting that it would be worthwhile doing a biopsy at the end of 6 months or 1 year of remission to find out if there are still histologically active, and that might mean that further treatment or aggressive treatment might continue for still some longer period of time, and that might probably provide us better short-term as well as long-term outcomes in these patients. What is the optimal treatment of patients with lupus nephritis? Varies. It depends on the type of the disease, histological variant. Is it class 3, class 4, class 5, or a combination of these? Whether clinically patient has nephrotic syndrome, which means proteinuria more than 3.5 grams per 24 hours, or there is renal dysfunction at the time of presentation. The immunosuppressive therapy is usually advised for diffuse proliferative lupus nephritis class 4, class 3 focal proliferative lupus nephritis, certain selected forms of membranous lupus nephritis. Steroids also may be used for lupus podocytopathy, which usually when you have minimal lesion, but if you have proteinuria, as I said, that somebody may have just podocytopathy, no other lesions, but nephrotic range proteinuria, they respond same way as minimal change disease with steroids, and usually steroids would be given. So it will vary depending on the clinical features, the renal function, as well as the histological type of disease. What are the risk factors of progression? So which patients out of those in whom you have found are likely to progress? Those who have elevated serum creatinine at presentation or at the time of biopsy. So renal dysfunction at presentation is a poorer sign of progression, is a sign of progression. Heavier the proteinuria, higher the chances of progression. Those patients who have hypertension, and especially uncontrolled hypertension. Anemia with a low hematocrit of less than 26%, and ethnicity, we will talk about it in greater detail. Histologically, if you have tubulointerstitial disease, extensive crescent formation, severity or frequency of relapses, when you treat these patients and you have frequent relapses and more severe relapses, then likely that this disease is going to progress, this patient is going to progress. Whether you achieve a complete remission or a partial remission. Those who achieve partial remission do not achieve the same kind of response as those who have complete remission. So patients who do not achieve remission or achieve a partial or a complete remission will have a differential progression. If you delay therapy, then these patients are also not going to do well. So if the diagnosis of lupus nephritis is made later, so earlier you make a diagnosis and earlier you decide to treat these patients, the better these patients are going to be. Those who have a persistent course, poor response, those who relapse more frequently, those who remit with hematuria, subnephrotic proteinuria, but have an active disease histologically. Sometimes proteinuria might decrease, but that's why the role of histology becomes important in trying to find out if there is a smoldering, clinically inactive disease. That also will progress. In a group of 1,000 patients, if you have higher rates of end-stage kidney disease in patients who had renal disease diagnosed 6 months prior to biopsy. So anyone with a longer duration of disease prior to biopsy, the rates of end-stage kidney disease will be 47 versus those who were diagnosed less than 6 months before the biopsy. So shorter the diagnosis to or biopsy interval, the disease interval, better the chances of survival in these patients for kidney disease. So factors which determine the overall outcomes in these patients would depend on complete or partial remission. If you achieve a complete or a partial remission or no remission, then you have obviously a better survival. Those who achieve complete or partial remission. Partial remissions are likely to relapse later and therefore will have poorer outcomes. Those who achieve complete remission, how do we define it? Inactive urine sediment, serum creatinine is less to normal or 20%, less than 20% than the baseline. The urine protein less than 500 milligrams per 24 hours. In people who achieved complete remission, in a study where 86 patients, 43% achieved complete remission. 5-year renal survival in these patients was 95% in comparison to those 46% who did not achieve remission. And the 10-year renal survival was 84% versus 31% in those who did not achieve remission. And 10-year patient survival was also better in this group of patients compared to those who had a partial remission. And those who have partial remission, it's defined as a 50% reduction in proteinuria, less than 1.5 grams of protein per day, or with a stable kidney function. And in the same group of patients, those who achieved partial remission, when they were followed for 10 years, those who achieved partial remission had a better response to renal outcomes, 45% versus 19%. And even the patient survival was better, 76% versus 46% in a group of patients with no response. So fortunately, there have been large number of studies in lupus nephritis where one can determine which patients are likely to show long-term good outcomes in these patients. So we have some guidelines and direction in that, kind of some scientific proof for outcome results in patients after treatment. Features which suggest progression. If you have a stable renal functions after 4 weeks on therapy, you have lower chronicity index on renal biopsy. People with white race and lower baseline proteinuria and creatinine are likely to have less progression in these. Patients with male gender, earlier development of nephritis from the time of diagnosis of lupus will have a lower likelihood of sustained remission. So the patients who will achieve remissions are those who have stable renal function after 4 weeks of lower chronicity, white race, and lower baseline proteinuria. Who are patients who are likely to relapse? Are patients who have nephritic onset of presentation or nephritic relapses. That means patients who have oliguria, hypertension, renal dysfunction, and proteinuria. Lack of response to therapy are likely to progress later. And the evidence for this comes from a paper from Moroni in Kidney International long time back. 70 patients, risk of doubling of creatinine or reaching end-stage kidney disease or a nephritic relapse is 6.8 times more in patients who have a nephritic relapse. Relapses occurring within 5 years after induction period also have a poorer outcome. And average relapse rate is about 8 per 100 patient years of follow-up. How is race and ethnicity important? And this has been, most of you who are aware of the literature about lupus and lupus nephritis is that the African American and Hispanics don't do as well as non-Hispanic and whites. Chinese and East Asian ethnicity also provides a different kind of responses to these patients. They seem to be responding better to a particular kind of drug, like mycophenolate mofetil has been very well studied in Chinese and East Asians. Then they show better response to mycophenolate mofetil than to cyclophosphamide. So worse outcomes for African Americans and Hispanics. Renal survival after cyclophosphamide therapy in diffuse proliferative lupus nephritis. 95% of whites show a better survival in comparison to 58% of African Americans at 5 years. So the independent of other risk factors like age, hypertension, activity, chronicity scores, ethnicity or race becomes an important independent risk factor for outcome measurements in lupus nephritis. Renal survival at 10 years was 38% in African Americans, 68% in whites, and patient survival was also better in the whites, 59%, 59% in blacks, African Americans, and 81% in whites. Out of 213 patients with a mean follow-up of 37 months, the incidence of doubling of serum creatinine or development of end-stage kidney disease was 31% in African Americans, compared to 18% in Hispanics and 10% in whites. So race and ethnicity determine the outcomes in this patient. So therefore, treatments need to be studied across the ethnic groups as well as multi-centric, multi-country trials are proven to provide the application of those treatments across your group of patients. Studies which have been done in limited ethnic groups may not necessarily correspond to the outcomes in your group of patients. So how do we treat these patients? You usually have an induction phase and a maintenance phase in these patients. And where initially there is an intensive immunosuppressive regimens, and then you give less maintenance regimen, immunosuppressive regimens as you continue to achieve. The remissions are usually achieved in about 6 months' time, but they might continue to be responding till about a year's time. Some patients might take a year to respond. And there have been predominantly two group of induction therapies. One is cyclophosphamide based. Usually you give NIH regimen 0.5 to 1 gram per meter square Q monthly for 6 doses. Or you could give a Eurolupus low dose regimen 500 milligrams Q 2 weekly for 6 doses. And or you could give an oral regimen of 1 to 1.5 milligram per kilogram per day, maximum of 150 milligrams for about 2 to 4 months, usually about 3 months or so, if you decide to. But with IV therapies, most clinicians have become so comfortable with that most of us have been using intravenous cyclophosphamide in patients with lupus nephritis. The other alternative therapies have been mycophenolate mofetil, which was, as I said, that in Chinese studied very well and now shown to be good in the randomized controlled trials, but they produce equally good, effective induction regimens for patients with lupus nephritis. Usually dosages which have been tried have been higher, 2 to 3 grams per day for 6 months, but many of Indian patients do not tolerate about 3 grams. So most of us have been using 2 grams. I still continue to favor cyclophosphamide. I will like to know Dr. Misra's sort of favorite as well. I know for many periods of time we have together used cyclophosphamide. I don't know whether he changed his regimen now after mycophenolate mofetil has become available. The trials initially showed that mycophenolate mofetil is equivalent to cyclophosphamide at 24 weeks equal, and at 3 years, better long-term kidney outcomes with cyclophosphamide. Meta-analysis of development of ESRD over time, 10% reduction in 1970 to 1990, when most of the therapy used was cyclophosphamide. This is a review article in Arthritis Rheumatology about 2016. And this looked at the overall outcomes of development of ESRD over the years, over the last 50 years or so. And it divided the 2 time frames, one from 1970 to 19 or early 2000s when cyclophosphamide was the predominant use. And there was a progressive decrease of about 10% ESRD risk over time. However, after the introduction of mycophenolate mofetil, and many physicians and rheumatologists and all, because they're scared of the side effects of the cyclophosphamide, have started using mycophenolate mofetil. And one could see that over the next 20 years, there wasn't any significant reduction in the development of ESRD after that. So suggests that probably cyclophosphamide may be, over a long period of time, a better drug. But I agree that mycophenolate mofetil in the randomized trials is found to be equally effective. What could be the maintenance therapy? The maintain trial showed that MMF was equal to azathioprine. We usually change patients to azathioprine after achieving the induction, and small dose of steroids. And many patients, I have been able to discontinue steroids in some of the patients, but some rheumatologists and nephrologists would continue steroids, small dose, throughout the life of the patient, or at least for 5 years or so. Maintenance arm of the arms trial showed that MFF was better than azathioprine. And so many people, those who use induction therapy with mycophenolate mofetil, will probably continue with mycophenolate mofetil, and that's what the guidelines are also suggesting. And the other people who have used cyclophosphamide, probably you could change over to either mycophenolate mofetil as maintenance or azathioprine. B-cell depletion therapies have also been tried. However, rituximab was not shown to be beneficial in a short LUNA trial. And B-cells, rituximab and B-cell therapies like belimumab and other trials, in this trial they combined it, but there wasn't any great effect. And in the guidelines also, as of now, the belimumab and all have been reserved as a therapy, although I'll talk about the BLISS-2 trial on the lupus nephritis, which came, I think, to 2020 in New England Journal of Medicine, suggested that when added as an induction agent, it provides a better outcomes in patients with severe lupus nephritis. Belimumab has been approved in the US for lupus, and now with the BLISS-2 trial, again has been, can be used now for lupus nephritis as well. I will not talk in greater details about these. Minimization of corticosteroids has been the cornerstone of the treatment over the last 2 decades or so. I think Dr. Misra will again probably want his comment on that. Initially, we were using higher doses of steroids, and it's become very clear, both, especially for nephrologists, using in the transplantation as well as across all diseases now, that the dosages of steroids have come down. And we've seen that probably smaller doses of steroids produce the same effects from efficacy point of view and lower adverse effects with lower dosages. So over the years, the dosages of steroids have come down. We were initially using 1 milligram per kilogram body weight. The dosages have come down to 0.5 to 0.7 milligrams per kilogram body weight maintenance, and then tapered quickly rather than slowly as was being done. So by the end of 3 months, you are at about 5 to 7.5 milligrams of prednisolone in most of the patients with lupus nephritis. So that has been another change. This has been across all diseases as well. I see it in transplant. I see it in vasculitis, and so is happening in lupus nephritis as well. And voclosporin therapy, especially with very low doses of steroids, showed the multi-target therapy, as I said, would combine the uses of tacrolimus, mycophenolate mofetil, and corticosteroids. So was compared with IV cyclophosphamide and corticosteroids, had better results at 7 years. But as I said, that this was best studied in Chinese, because these are Chinese studies, and is not being as well replicated as such. At the moment, it is being kept as a alternative therapy to patients who do not respond to cyclophosphamide. And one can use tacrolimus, mycophenolate mofetil, and corticosteroids in a group of patients who do not respond to either mycophenolate alone or cyclophosphamide. And this is the voclosporin trial that I was talking about. And this trial was a double-blind, randomized, multicentric, placebo-controlled trial, 142 centers, 27 countries, class 3, 4, and combinations of lupus nephritis, 178 in placebo, 179 in voclosporin, 52 weeks. Voclosporin has an advantage that it's used, doesn't require any monitoring. It's like one of those calcineurin inhibitors like cyclosporin. and 23.7 milligrams given twice with low-dose steroids. Quick taper, 40% achieved remission in comparison to 23% in the placebo, and the mortality also was lower in the voclosporin group. So overall, good response to voclosporin. At the moment, not available in our country, approved in the US now, but not yet available in our country. So hopefully this would become available, and maybe we will have this drug also as available as an option. The other drug, which was, this is where you can see that the blue ones are the placebo group, the voclosporin group, and the pink one are the placebo group. And you can see that higher response rates for voclosporin, both complete as well as partial remissions, and both at 24 weeks and at week 24. And you can see the probability and intention to treat study showing better results with voclosporin than with the standard of care to which it was compared with mycophenolate mofetil. And this is subgroup analysis also showing voclosporin being effective and better for voclosporin than placebo in this group of patients. These were the adverse effects, which were not also very different. And this is the belimumab trial, which was again published in New England Journal of Medicine. Again, I'll not go into the details of it, but you can see that probability of the renal responses were much better in the belimumab group than in the standard of care. You can see here the probability of, again, achieving renal events was and the much lower in belimumab in compared to placebo. Another point which I would want to suggest is that we should provide prophylaxis for preventing infections. And obviously, this is a disease which occurs in young females, and I think one needs to talk about the effects of therapies as well as disease on the gender. We need to talk about fertility in these. This is involving ladies with fertile periods. So trying to prevent infections because of therapy, as well as trying to see that they are able to achieve their goals of having children and be able to produce children. These talks and the discussion about the toxicity to the gonads related to our therapies need to be discussed with these patients. There are newer targets which are being targeted in lupus nephritis. Lupus is a classic autoimmune disorder involving dendritic cells, B cells, and T cells, and there is huge interaction between these. I don't have to tell it to rheumatologists and immunologists that there is a huge interaction between these. And there are multiple targets which are being looked at. And one target which we've been interested in and we've started some investigations is itolizumab or CD6 molecule ALCAM interaction. This is CD6 ALCAM interaction, which is a co-stimulatory molecule on the immune activation pathway. And obviously, with this interaction, there is increased co-stimulation, and obviously an immune activation occurs through this process. So this has been documented to be highly activated in patients with many autoimmune disorders and inflammatory disorders. And so has been documented to be in lupus nephritis. And therefore, and this drug, itolizumab, is inhibiting this interaction and doesn't allow the immune interaction, is available in our country for use. It was used for psoriasis. And we got interested into this, and we've started those of you who are interested in reading about this, I would suggest this JCI article, and it gives you all the information about the contribution of CD6 ALCAM interaction in lupus nephritis. You can see that this is expressed, CD6 is expressed in lupus nephritis, shown in blue in the renal leukocytes and the urine leukocytes, as well as in the renal epithelial cells in the lupus nephritis patients. And This is after the animal experiments, we found that 1.6 milligrams per kilogram dose was the best dose. And after the dose finding studies, the human studies have been started in this, and we've started a study, E. coli study. This is a multicentric, multi-country phase 2 trial on itolizumab in patients with lupus nephritis. And we will have phase 3 trials as well after the phase 2 trials show some success in this group of patients. So ladies and gentlemen, let me stop here and sort of summarize that lupus nephritis is a complex disease with variable course and response to treatment. Cyclophosphamide and mycophenolate mofetil are equally good for induction of remission in severe lupus nephritis. This is 1A. However, other drugs like voclosporin and belimumab have all been shown to be effective, but yet not come into the guidelines as such, but I'm sure they will come into the guidelines. So you have a lot of choice now in inducing remission in many of these patients, and choosing these therapies appropriately for your patients will be important. In patients with rapidly progressive renal failure, intravenous methylprednisolone 250 to 1 gram. As I said, reduction of steroids is important, given for 3 days, and then you can start the other therapies like IV cyclophosphamide. Usually in presentic and severe lupus nephritis, most nephrologists and most rheumatologists probably prefer cyclophosphamide to mycophenolate mofetil. Maintenance therapy can be done with either azathioprine or mycophenolate mofetil, and you will achieve complete remission or partial remission in a significant number of patients, 18 to 24 months. Or longer therapies need to be continued for 3 to 5 years in these patients. Maintenance therapy could be with aza and mycophenolate mofetil. In patients with mycophenolate mofetil induction, the recommendations suggest to continue with mycophenolate mofetil, but in those with cyclophosphamide, you could use either mycophenolate mofetil or azathioprine. In patients with cyclosporin induction, MMF or AZA can be used. AZA obviously is preferred in patients with who want to become pregnant, and prednisolone dosages are usually 5 to 7 milligrams. The standard of care for lupus nephritis has improved over the years and has improved survival significantly, but there are still significant unmet needs. And that's the reason people are still looking at newer and newer molecules, and the CD6 ALCAM pathway seems to be one of those pathways. I'm not saying that that's the only pathway. People are looking at multiple pathways. APRIL and other molecules are also being targeted. So we will have probably newer therapies which might provide us better and safer therapies for our patients with lupus nephritis. So thank you for your patient hearing. And I'll, after the lecture with Dr. Misra, I'm sure we're going to have questions and answers. Thank you very much.
Thank you, sir. Thank you for excellent talk. Now I request Professor Misra, sir, to discuss about anti-phospholipid antibody syndrome.
Thank you, Banwari. It was nice listening to Professor Vijay Kher, whom I started my professional life at Sanjay Gandhi together, and sir was an excellent support, and we had agreement on management in lupus nephritis. That made things so easy. Coming back to my topic, it's anti-phospholipid syndrome, practice tips. The picture on the right is that of Graham-Hughes. It's also called the Hughes syndrome and was described in 1983 when I was I was working at the Charing Cross, and Graham-Hughes worked at the St. Thomas, and he and Nigel Harris and there was an Egyptian also, who described this antibody for the first time in patients with lupus. I think their series had 150 patients or so, and roughly 33% of patients had these antiphospholipid antibodies, which was also called lupus anticoagulant at that time. And basically, those patients who had biological false positive for VDRL, they were tested for cardiolipin. You know that VDRL test is an agglutination test, which the antigenic mixture is that of lecithin, cholesterol, and cardiolipin. They refined this VDRL test to anticardiolipin test, and a syndrome was, in fact, described or discovered. It's also called the Hughes syndrome. My scheme of presentation will be what is APS, the classification criteria. There is a proposed revision of the criteria and the clinical features of APS, APS nephropathy, catastrophic APS, high and low risk thrombotic events, mechanism of thrombosis, and the management. APS, or antiphospholipid antibody syndrome, is defined by an antibody. So all the patients should have the antibody positive. There are clinical criteria. You need one clinical criteria plus a lab criteria to call it. The clinical criteria is vascular thrombosis, arterial, venous, or small vessel thrombosis in any organ, and the pregnancy morbidity is a fetal death beyond 10 weeks, or premature death less than 34 weeks, but due to eclampsia or placental insufficiency, and 3 consecutive spontaneous abortion in less than 10-week gestation. It is well known that in less than 10-week gestation, abortions is commonly due to chromosomal abnormality. However, if there are 3 consecutive spontaneous abortion, one suspect that it could be antiphospholipid antibody syndrome. The laboratory criteria is a positive lupus anticoagulant on 2 occasions at least 12 weeks apart, the presence of IgM or IgG-ACL at least more than 40 GPL or MPL on 2 occasions, again at 6 weeks interval, or the presence of antibodies to beta to GP1, IgG or IgM in high titer, which is usually more than 40. The lupus anticoagulant is a functional test and have a stronger association with clinical features such as pregnancy, morbidity events, or thrombosis. Anticardiolipin antibodies and beta to GP1 are, in a sense, a structural asset. You just find out the amount of antibody, not necessarily the ones that are biologically active at the vessel level. So, but the other side is lupus anticoagulant do have difficulty in standardization, whereas cardiolipin and beta to GP1 commercial available kits are available. It is reproducible, easily doable, and variation from one lab to the other is less than 10%. The antiphospholipid antibody is a spectrum of antibodies. our old VDRL, which is probably not used as a test for syphilis anymore. It was widely rampant during the war, is an agglutination test. Anti-cardiolipin antibody was described in 1980. Lupus anticoagulant is a functional assay that was described 4 years earlier to the anti-cardiolipin antibody. Antibodies to beta-2 GP1 was described later than anti-cardiolipin antibody. And these are the two antibodies which are called non-criteria antibody, means phosphatidylserine and phosphatidylethanolamine, and antibody to the prothrombin activating complex are also part of the phospholipid antibodies. The reason beta-2 GP1 is important, it was soon shown that anti-cardiolipin antibody alone probably doesn't do much of functional abnormality. It is the mechanism of action of anti-cardiolipin antibody is binding through the beta-2 GP1, and therefore there is a kind of clinical importance given to the presence of both anticardiolipin and beta-2 GP1 if both are targeted. So we need a positive lupus anticoagulant or anticardiolipin antibody, either IgG or IgM, or a beta-2 GP1. You need any one of them. If you have three, well, as you will show in my later slides, that has a different connotation. Both of these tests, any of these tests, has to be present on two separate occasions, at least 12 weeks apart, but less than 5 years. I mean, you can't have a test now and after 7 years, and you call it anti-phospholipid antibodies. If they are negative to either of these, then you suspect there is clinical suspicion of thrombosis. Then of course you need to do a IgA anticardiolipin or IgA beta-2 GP1, which is not freely available. You can do also antiphosphatidylserine or phosphatidylethanolamine, but again, these are not widely available. The lupus anticoagulant is a tricky test. It has to be a prolongation of APTT or dilute Russell vapor Benham time, which is called a screening test. And then a mixing experiment is done with 1:1 normal pool plasma, which is poured in platelet. If it is corrected, then you attribute that to the presence of a deficiency of factor 8 or 9, as you know, which happens in hemophilia or Christmas disease. But if it is not corrected and it is shortened after addition of significant phospholipid, then lupus anticoagulant is confirmed. Well, many labs now do the test as per the standard protocol by the International Committee or Society on Thrombosis. So, but earlier in our days, when we started life, professional life, lupus anticoagulant was difficult to interpret. This is a mechanistic slide. It tries to show that the anti-phospholipid antibody or the anti-cardiolipin antibody, be it any form, it acts through beta-2 GP1. And without beta-2 GP1, much of its action on the endothelial cell wouldn't occur. And once it does bind to the endothelial cell, then, of course, there are two things. One is an inflammatory cascade occur. A clot is formed. And also there is activation of inflammatory cells and endothelial cells. So it's a combination of inflammation and thrombosis. Generally, we do find the thrombosis picture in histology, and inflammation is probably predates the thrombotic events. Now, when to suspect APS? It's a young stroke or an MI, deep vein thrombosis of the lower limb, pulmonary embolism, pregnancy morbidity as was highlighted, and if there is a connective tissue disease like SLE. Remember, SLE was the first disease in which the antiphospholipid related scenario was described. And the theory of thrombosis is that not only you need antiphospholipid antibody, you need a second hit. It could be an infection, it could be a surgery, it could be a presence of connective tissue disease, or the standard risk factors that is seen in cardiovascular disease, the presence of hyperlipidemia or dyslipidemia, hypertension, uncontrolled diabetes, and smoking. These four are the standard risk factor for cardiovascular or cerebrovascular thrombosis. The presence of that also, would make our antiphospholipid antibodies a very pro-thrombogenic potential. This was a series described by Cervera from Spain. It took about 13 or 14 countries, and there were 20 centers. Each center were asked to contribute 50 consecutive patients, and this was probably the largest series of patients with APS that has been described. What it tells us is the prevalence or occurrence of clinical feature in these. As you can see, the DVT was present in 317 or 31%, thrombocytopenia between 50,000 to 150,000 in 21%, livido reticularis in 20%, stroke in 13%, superficial thrombophlebitis in 9%, and pulmonary embolism in 9%, fetal loss 8%, TIA in 7%, hemolytic anemia in 6%, and skin ulcers in 4%. So if you see that even if you had antiphospholipid antibody syndrome, good number of patients had thrombosis, thrombocytopenia, livido reticularis. In SLE cohorts, if you look at the other way, SLE cohort, there would be 40% of the patients would be having the presence of antibodies alone. Yet, the patient who fulfilled the criteria of antiphospholipid syndrome would be much lesser, anything between 10 to 15%. The initial criteria of it's called the Sapporo criteria, 2006. It did not take into account a number of clinical features which were subsequently described to be associated with the antibody. And these include thrombocytopenia. The initial Graham Hughes and Nigel Harris series had three things that were associated with the antibodies: the vascular thrombosis, the pregnancy morbidity, and thrombocytopenia. But in the criteria that was devised much later, thrombocytopenia was dropped. Hemolytic anemia, and this is without cystocytes, so that is no intravascular hemolysis. Renal, we have two important complications: acute thrombotic microangiopathy and a chronic vaso-occlusive lesions. Cardiac valvular abnormality includes valve thickening of the valve, irregular nodules, and dermatology, we have livedo reticularis, or representative picture is shown here, and in neurologic cognitive dysfunction in absence of stroke. Well, there is a new criteria which is looking at, or which has been proposed, including some of these non-classical criteria clinical features. So the initial criticism to the Sapporo classification is that there was no risk stratification, there was no clear definition of the anti-phospholipid antibody, and heart valve disease or thrombocytopenia was not put in the criteria. So this has come out a new criteria by the ACR EULAR group, as they are doing in most major connective tissue disease. And you see that the criteria, laboratory criteria, is unchanged, and the new clinical criteria has newer domains like macrovascular, microvascular, obstetric, cardiac valve disease, and also platelet count, less of platelet count. APS nephropathy has been an important recognition in patients with primary or with SLE nephritis. There is a Thai study of 150 consecutive patients which have been retrospectively analyzed. And when they did the biopsy, they found the figure as high as 35% have not only SLE, have nephritis, but it could additionally qualify for APS nephropathy. There is a treatment importance. If a patient is diagnosed to be APS nephropathy, you would give anticoagulation as opposed to immunosuppression. The initial Cervera cohort, the European cohort, had 2.7% patients with APS nephropathy, and the features were glomerular thrombosis, renal infarction, renal artery thrombosis. To diagnose APS nephropathy, you need at least one acute lesion, that is thrombotic microangiopathy, and one of the chronic lesions, fibrous intimal hyperplasia, organized thrombi, fibrous arterial and arterial occlusion, and subcapsular zone fibrous cortical atrophy. I think it is worth to talk to the histologist, if you are doing renal biopsies, to tell them that to look for these features if the patient have one of the antiphospholipid antibody positive. Catastrophic APS is seen in less than 1% of patients with APS, but it has high mortality because there is evidence of involvement of 3 organs and development of manifestation simultaneously in less than 1 week, and a demonstration that there is a small vessel occlusion at one of the organ tissue side and of course, the presence of either lupus anticoagulant or anti-cardiolipin antibody. It's a definite caps if all four are there. Most patients of these would be found in ICU setting, and they would be confused with septicemia or thrombotic thrombocytopenic purpura, but catastrophic APS are being considered more and more. The most common precipitating factor is infection, and the first clinical manifestations like pulmonary or ARDS and renal involvement is common. Of course, you need to demonstrate the presence of lupus anticoagulant or thrombocytopenia. So this is a very practical question. What is the risk of vascular thrombosis if you have anti-cardiolipin antibodies with or without a connective tissue disease? The risk is 1% if without. If it is with disease like SLE, the risk increases to 5%. And the risk factors are a persistent high anti-cardiolipin antibody, a previous multiple thrombotic events, and of course, cardiac abnormality. The new risk stratification profile categorizes patient into two, a high risk and a low risk. High risk is triple antibody positive, presence of lupus anticoagulant, presence of anti-cardiolipin antibody more than 40 GPL or MPL, and beta 2 GP1. If all three are present, then there is a high risk of thrombosis after a thrombosis. So if there is an event and you have all three, then it's a high risk for having a second thrombosis. Low risk if it is isolated anti-cardiolipin antibody at low titer less than 40, and if at double testing or twice testing, once it is positive and once it is negative. In a newer mechanism of vasculopathy, the mTOR pathway has been factored into, and therefore one finds a role of sirolimus in the management of this. The treatment guideline for secondary thrombosis, that means once you have the thrombosis, and for a venous thrombosis, you treat with standard vitamin K antagonist oral to have an INR of 2 to 3, and the evidence level is 1B. And this often is asked how long to continue. It has to be continued indefinitely. There is no distinct advantage of the direct anticoagulation like rivaroxaban, even in triple antibody positive. If the patient has venous thrombosis and develops a venous thrombosis despite anticoagulation, oral anticoagulation, then of course we aim to achieve a higher target 3 to 4 and change to low molecular weight heparin. This is of course evidence is low, but that is what those who manage these patients to try to increase the INRs to 3 to 4. With arterial thrombosis, again the recommendation is that of oral anticoagulation after initiation with heparin we first try with the conventional heparin, change over to, and the recommendation is 2 to 3. But one has to be careful with a stroke. My neurologist colleague advised me, even if it is a young stroke and anticardiolipin positive, don't anticoagulant soon after the stroke event. You can wait for 2 to 3 weeks because the risk of hemorrhage or thrombosis stroke may have hemorrhage inside the mass, and that could be disastrous for the patient. Again, no recommendation as yet for direct anticoagulation. Again, for arterial thrombosis, if the treatment is not satisfactory, the INR value, and there is recurrent arterial thrombosis, aim for a higher INR and add low dose aspirin or switch to low molecular weight heparin. Obstetric APS, there is high risk, that means the cardiolipin antibody are positive, but there is no thrombosis or no pregnancy complication. Well, we have fought with obstetrician all the while, and they would put these patients on low molecular weight heparin. The recommendation is not there. But you cannot win a situation with the obstetrician during a pregnancy. I mean, it looks like it is better to succumb to them, but they do prescribe low molecular weight heparin, and well, I find myself helpless. But the science behind it is not there. If there is a morbid event, then of course, both LDA and low dose aspirin and heparin to be given. The evidence for the strength of the recommendation is 2B. Again, if there is a delivery less than 34 weeks, a premature delivery due to preeclampsia or placental insufficiency, then heparin is indicated. There is some controversy in obstetric. This is if you are positive for APL, to prevent a primary thrombosis, the recommendation is, the strength of the recommendation to a aspirin can be given. SLE with no thrombosis of pregnancy and high risk profile, patients are given LDA. There is a very strong recommendation if it is associated with any CVD risk factor like smoking, hypertension, diabetes. You have to address those issues like you address issues of SLE. You treat SLE, and to prevent a thrombosis, if it is a low risk APL profile, that means one of the antibodies is positive, then maybe LDA may be considered. Non-pregnant women with history of obstetric APS, this is again low dose aspirin only. The CAPS algorithm is somewhat fluid. Like people in ICU doesn't tend to follow any protocol. The patients have got very high mortality. Whoever it is, if it is a life-threatening condition, you give high-dose steroid, methylprednisolone, plasma exchange, and effective anticoagulation with intravenous heparin. If there is still no improvement, then you give cyclophosphamide. Well, there is no trial to suggest either of the things, but you do all these things to help your patient, because catastrophic APS has a high mortality. Sirolimus use, recently David Cruz was there in the Calcutta meeting, and he said that with the use of sirolimus, the outcome of graft survival after transplantation is much better, even in patients who are APS. And there were biopsy lesion to biopsy to suggest that those who had APS and on sirolimus, they were less of fibrosis. So summary, if asymptomatic, only follow-up, no active intervention. Thrombosis, anticoagulation. Bad obstetric history, you with a single second trimester or single pregnancy low, only prophylactic. Isolated skin, no treatment. Neurological, consider anticoagulation. Cytopenia, evaluate for SLE. Well, I'm thankful to Dr. Prakasini, who helped me prepare the slides. Thank you.
Thank you, sir, for excellent presentation. Now we have some questions to discuss. First, I start with Professor Vijay Kher, sir. Question is there any specific guidelines for duration of steroids without immunosuppression in minimal change disease or podocytopathy in lupus versus non-lupus?
Yeah, actually, even in lupus, we would treat, if there is nothing else on the biopsy, no proliferative lesion, only podocytopathy. We see it sometimes in patients with lupus nephritis. So what I would do is, the general recommendations for this is to treat it like a minimal change disease, as you would do in any other patient. Usually start with steroids. We usually do 1 milligram per kilogram body weight in an adult. In children less than 10 years of age, usually 2 milligrams per kilogram body weight to start with. Once you achieve a remission, then you make it into an alternate day, taper it slowly over the next. So usually treatment would go on for about 3 to 4 months, and most of these patients would respond to steroids extremely well. And if there is no other reason to continue steroids, then I would stop steroids in them after about 4 to 6 months. Okay.
And how to monitor these patients, sir?
Usually with proteinuria. And obviously, you will look for urine routine examination. We usually do urine routine examination in patients with lupus on a monthly basis, just to see that there is no activity or transition into a proliferative kind of a lesion. And that would be done for any other lupus SLE patient on a regular follow-up. Also, I'm sure the rheumatologist would do a urine routine examination to see that there is any evidence of red blood cell WBC or a WBC cast or a RBC cast, and some degree of albuminuria or proteinuria in these patients. So that's the time to suspect lupus nephritis, and I would do a biopsy at that point of time. That's to pick up lupus nephritis early. And I would think that being a nephrologist on the other side, having seen some patients from rheumatologists, that every patient of lupus, once you see them maybe once in 3 months, 6 months, do order urine routine examination and kidney function tests in every visit of your patient in lupus nephritis. And in these patients, I would also look at for urine activity. If there isn't any urine activity, not do anything else, and taper off. And then follow regular follow-up every 3 months at least. If there are no other clinical signs, even then we would follow up these patients on a regular basis for every 3 to 6 months.
Dr. Misra, sir, would you like to add something?
Yeah. First of all, I would Dr. Kher was kind enough to mention my name a couple of times. As to 3 things he said. My favorite inducing regime, injection cyclophosphamide or mycophenolate. I would vote for cyclophosphamide. The reason is I am very skeptical of patients these days who do not follow the prescription as it is written. Means you tell them to take 2 grams of mycophenolate, and whatever reason that may be, cost could be one of the important reasons, they take half of the drug. So I generally feel that patients in general are relying half the what we say. I mean, if Dr. Kher might say they will rely 75%, but my patient, I think, even reduce the other drug to the point of their convenience. But cyclophosphamide is one drug, it's given in front of your eyes, your resident do it, or your nurse do it, and you know 6 doses have gone in. And if you are on a urolupus and there is still disease activity, then you can extend 3 more doses for both NIH. So my favorite drug for Indian patient or Asian patient is cyclophosphamide. And probably I feel that many of our patients we have seen during the time when Dr. Kher was there, they had a very good outcome. I mean, you look at the cost. The cost is a significant difference. The second thing was a very important issue raised by Dr. Kher was reducing the steroid or minimizing steroid dose. I do believe in it. Though I don't believe in stopping it, I do believe that if you give methylpred bolus, and probably we should try that, 3 doses with cyclo, we can taper it down to a 0.5 milligram in the first 3 months or 2 months. And if you are bold enough, we can try with 10 milligram or 15 milligram. Why not? I mean, unless we do it, who will do it for us? And David Cruz from the University College Hospital, there was a meeting Alakendu Ghosh had organized at Kolkata, and he said people are trying. I mean, they are trying to push the steroid initially for 3 days, and if needed, after a month you can give another 250 milligram of mini bolus, but give 10 milligram, no more than that. I am yet to dream of a 0-dose steroid like they are trying for avocapan study in vasculitis, but I am not that bold. I would agree steroid for podocytes, as Dr. Kher said, and the thing is that there is a little difference. When we give cyclophosphamide, we have to be patient. You can't be at the end of 6 months, you try to see whether remission is active. It is better to wait for 1 year. Do rebiopsy, I'm not saying that, but you wait for that time because cyclophosphamide acts little longer. I mean, the main effect of it may come in 1 year, and some of the Americans feel that it is 18 months even, cyclophosphamide effect lasts. So to think of that it is only caused a partial remission. We have seen patients who have been partial remission at the end of 6 months. They do so better profile at the end of 1 year. But Dr. Kher lecture was very practical.
Sir, any other supportive therapy along with steroids, like ACE inhibitors or something?
Oh, yes. For proteinuria, routinely ACE inhibitor are being prescribed. And many of our patients, probably the proteinuria profile is better on patients who are on ACE inhibitor.
I think, Dr. Banwari, one point here. I think somebody has also asked about the ACE and ARBs, and Dr. Misra was talking about it. I think ACE and ARBs, especially when you have stabilized the acute activity of the disease, at that point of time, probably most of patients of lupus nephritis would require ACE and ARBs to further lower down the degree of proteinuria. Sometimes many patients who have recovered all the clinical activity of lupus, proteinuria might continue to some extent, and that proteinuria is related to the sclerosis of the glomeruli. Glomerular sclerosis which has occurred may not necessarily mean always an activity of lupus. So that has to be distinguished between. So there is distinction between increase in proteinuria related to glomerular sclerosis, which is a chronic damage which the kidney has suffered because of active lupus, and therefore you would require antiproteinuric measures. So I would say that one should continue to use it. Don't get worried about deteriorating renal function. These days, there is enough evidence that you can use ACE and ARB safely in vast majority of patients with stage 4 and stage 5 kidney disease as well. Many of my dialysis patients and those who are not on dialysis with CKD5 are on ACE or ARBs. ARBs much more than ACE inhibitors these days because they have become much cheaper now than ACE inhibitors, almost same price. So I would feel that probably angiotensin receptor blockers would be used in vast majority of these patients. Occasional patient might show hyperkalemia. And if there is somebody who continues to have higher degrees of hyperkalemia, usually I would feel that then one might have to use other drugs. Unfortunately, these days for other antiproteinuric drugs, SGLT2 inhibitors and finerenone, the non-steroidal mineralocorticoid receptor antagonists, are again another group of drugs which have been used for reducing proteinuria as well as slowing down the progression of chronic kidney disease in patients after the lupus activity has been subsided by the immunosuppressive therapy. Many of these patients on long-term basis may have some renal dysfunction, some proteinuria, and they are on a very small dose of steroids. Like Dr. Misra said, that he is not bold enough to say that he would withdraw steroids in most of these patients, but I'm glad that he's agreed that the dosages of steroids have gone down. And these days, instead, even in the induction, the recommendations now, KDIGO recommendations and EULA recommendations suggest 250 milligram of methylprednisolone rather than 500, or the recommendations still say going up to 1 gram, but more and more people have started cutting down on the dosages. And at least in transplantation, we find 250 milligram was equivalent to 500 milligram and 500 milligram was equivalent to 1 gram. So they seem to be producing beneficial effects during those in the induction days. So I think I would agree mostly with what Dr. Misra has said about low dose steroids and all, which is becoming an important element. And I think the side effects of steroids have been major side effects which have been seen in our patients. Cosmetic effects these days are becoming important. They may not have been important in the era in which Dr. Misra and I practiced, but these days younger patients with lupus may not want those side effects, adverse effects, and may sort of go against these therapies and may not continue these therapies. So it's good to find therapies which produce less cosmetic side effects as well as other adverse effects, there's no doubt. But I agree that steroids remain the cheapest form of an immunosuppressive drug for Indian patients.
So the next question is, what protocol of cyclo is better, NIH or Eurolupus? I think the answer is both have same equivalent efficacy. Sir?
Yes, I would agree. Eurolupus provides a fixed dose, 500 milligram for every patient. Is easier in protocol, whereas you could make mistakes in the NIH protocol, milligram per meter square and all those kind of, your nurse and some other juniors might make mistakes in calculating the dosages. Most of us have now shifted to Eurolupus by and large, but we have grown in NIH era for many years. During the days when Dr. Misra and I practiced together, we were using NIH protocols. And that was early 90s. That's what we grew on. But I think we have shifted. I don't know about Dr. Misra, but I'm sure Dr. Misra would have
we
also
have shifted
to Euro Lupus. And I think Euro Lupus dosages are easier in protocol to monitor as well as to give.
So the next one is, what is the approach when patient develop significant neutropenia after second dose of cyclophosphamide? I think we have to withhold for time being.
Yeah, usually bone marrow will recover in these patients. An occasional patient might show an adverse effect. And if the recovery has not happened completely, but you are okay to give a second dose, then you can reduce the dosages of the next one and then till the bone marrow recovers. Or you can hold it for some period of time, delay it by 2 to 3 or 4 weeks.
Yeah. Sir, Dr. Misra, can we use subcutaneous heparin in obstetric APS over low molecular weight heparin if there are cost constraints?
Oh, certainly. It was the unfractionated heparin that was initially used. Then came the low molecular weight. So 5,000 subcute either once or twice is a standard prophylactic dose. By any chance, if there is a cost constraint, please be remember that it was the unfractionated heparin where we started our life with APS. Low molecular weight heparin was then expensive. So, doctor, you can easily use it.
Sir, the next one is APS in patients of CTDs. Other than lupus presenting with stroke or DVT, should we screen such patients for possibility of secondary APS? Yes.
Yes, by all means you do. But remember that if it is not SLE and rheumatoid or systemic sclerosis or primary Sjogren's, please consider screening for the risk factor associated with CVD. That means for dyslipidemia, BP, hypertension, and smoking. Because any day, these risk factors outweigh the presence of anti-phospholipid antibody, but do screen for anti-phospholipid antibody and look particularly for lupus anticoagulant of beta-2-GP1. Anti-cardiolipin alone is a weak thing.
Vascular disease, Dr. Banwari, vascular disease in patients of chronic kidney disease is very, very common. Calcium, bone mineral disorders, and calcium deposition in the vascular calcification occurring in many of these patients of chronic kidney disease predisposes them, irrespective of whether the APS is there or not, to either bleeding or to thrombosis. So both the scenarios are present in patients of chronic kidney disease. So I think that, yes, I would not say that you should not screen for APS. If there is an indication and there is a suspicion that this may be aggravated by the APS, then I think we should screen for it. But there could be other factors, as Dr. Misra was saying, that atherosclerosis is very, very common in patients of chronic kidney disease. Bone mineral disorders with vascular calcification causing similar symptoms might be very, very common in these patients in the past.
Sir, what I meant was, don't take anticardiolipin antibody too much. I mean,
too much, yes.
You don't jump that it is positive and therefore this and that. Always remember that our traditional risk factor for thrombosis, you keep an eye on them.
So the next one is role of immunosuppressive agents in primary APS having recurrence of thrombosis in spite of adequate anticoagulation.
Well, there is no recommendation, but if it has, there is a recurrence and you have made your INR 3 to 4, you can try with hydroxychloroquine. Hydroxychloroquine has seen to some play, but I am not sure whether immunosuppressive drug in the category of cyclophosphamide, mycophenolate, or even azathioprine can have. I'll be hesitant to use it. Well, people have tried even rituximab, thinking it's that there are antibodies. Why not remove it? But we don't have published literature or evidence to support it. Mind you, anti-phospholipid antibody is primary, is still a rare disease. It's difficult to do a randomized controlled trial. I would be hesitant to use immunosuppressive drug.
Sir, Professor Kher, according to the biopsy algorithm, after complete remission, to consider tapering drugs, a rebiopsy is indicated, and if there is no activity, taper is considered. But it was also mentioned that patients who have achieved complete remission, 33% have active histological activity. So how do we interpret this, and how relevant is rebiopsy to determine taper or stop therapy in complete?
I think Brad Rowan, who has been one of the authors on the KDIGO guidelines, and I think there is a debate on that. This is not something that has been suggested as a guideline as yet, but because there is no guidelines usually want to look at randomized trial. There's no trial which people have done that with biopsy, without biopsy, and then see whether that has led to an improvement. But there is no doubt that there is poor correlation between clinical and histological evaluation in patients, especially in patients with lupus nephritis. So there is an increasing kind of favor for biopsying these patients, even though clinically they may not appear to be much of an activity. Many of these patients take longer time to achieve remission, and I would agree 100% with them. Many of our own patients we have seen at 6 months did not show that kind of response, but we continued with the same therapy. We did not change. We continued with the same therapy, and significant number of patients at 1 year had achieved remission, which was not done. So if we had kept the target at 6 months, we would have missed many patients achieving remission and unnecessarily changed the course of action in these patients. So I would feel that I would tend to biopsy. I am an aggressive biopsier as such. As a nephrologist, I would want to know more. I don't think there is a test which tells me whether this patient has achieved complete histological and clinical remission. Most of the time, I would trust my own gut feelings, and all those are all right. But then to be sure that we have achieved a good remission, it would be good to know. Biopsies have become safer with the ultrasound. I have also grown. See, Dr. Misra and I have been from an era, it only tells about our age. We have grown in an era where we have done biopsies without ultrasound. We've done biopsies with thick needles, 14 gauge needles and all. So we, Wim Silverman needles, where we had to rotate the needle. So it's been a safer kind of an era. Biopsies have become safer. So I would biopsy such a patient more and more and try to find out. But I agree that there is no guideline. I would get as much information for my patient to see whether it is safe for me to taper these drugs and try to do that. My mentor, Victor Pollock, biopsied lupus patients 6-7 times. He would carry a biopsy gun. In 70s, I'm talking about, in his pocket, and he would biopsy them. And the other point which I wanted to make was about this APL and in SLE patients. He way back in 70s, late 70s, described the TMA in patients with lupus nephritis. In fact, he was so gaga about it, and he used anti-snake venom at that point of time. Viper venom, anti-snake venom, at that point of time to declot these glomerular thrombi in these patients. And if you see the medicine journal in 1973 with Victor Pollock, you will see his article on Ancrod, which was the anti-snake venom used for declotting the glomerular TMA in way back in 70s. So way back before the APS and other syndromes were being talked about in that kind of a fashion. But those are the visionary kind of people who can look at that. And I would say that, yes, I would biopsy, try to biopsy whenever patients agree and if one wants to need to know more.
Sir, do you treat APS nephropathy patients in lupus with immunosuppression or anticoagulants or both?
No, if they need immunosuppression for lupus, they would need immunosuppression, and then you might have to add an anticoagulant. And that's happened in some patients. You will need anticoagulation as well. And lupus, as Dr. Misra said, is an important cause of APS, and I think those patients will require anticoagulation along with immunosuppressive drugs.
So, Dr. Misra, can VDRL, a much cheaper and easily available test, be a surrogate test for LAC in resource-poor setting?
Who is it, Dr. Ankur Dalal?
Yes, sir. Ankur.
Yes, I will tell you that for Dalal. VDRL is positive in 100 consecutive patient in lupus in 4%. You do lupus anticoagulant, you would find it in 15%, 15 to 20. And you do anticardiolipin antibody, you will find it in 30 to 40%. In my own series, I'm saying 4%, 15%, 30, 40%. All those patients, now it is up to Dr. Dalal to rely on a test which is 4% positive. VDRL positive in lupus, that is false positive VDRL is in 4%. Means the sensitivity is poor. We can't say that low cost means that you miss a diagnosis of lupus. So it cannot.
Sir, we will take one more question because we are already 12:42. So this is to Dr. Vijay Kher, sir. How long can we use calcineurin inhibitors safely? How long?
The usual therapy for patients with lupus nephritis, most of the therapies have been given for 3 to 5 years. Most immunosuppressive maintenance therapies have gone for this. And if patients remain well without relapses or without any flares, then obviously you would want to discontinue these therapies, especially the immunosuppressive therapy. As Dr. Misra said, that many rheumatologists and nephrologists would continue small dose of steroids, which would be 5 milligrams, sometimes 2.5, 7.5 milligrams, varying with the comfort of every nephrourologist. However, since many people have started trying to use less steroids, so it is quite likely that either mycophenolate mofetil might continue and you have no steroids, small dose of mycophenolate mofetil, or in some patients, people might continue, voclosporin becomes available, voclosporin, tacrolimus or cyclosporin. Small dose of tacrolimus and cyclosporin might continue for lifelong in these patients, like we do for transplant patients. Tacrolimus or cyclosporin is continued lifelong, mycophenolate mofetil or one of the other, azathioprine, is continued lifelong in transplant patients with steroids, small dose steroids. So it's quite likely that in some of these patients, you might modify. At the moment, there are no guidelines on these, and I wouldn't say you would recommend it, but yes, that's quite likely that you might continue one of these drugs on a long-term basis. I have had patients who haven't liked steroids and have remained on mycophenolate mofetil or azoran on a long-term basis, continue. I would not be surprised that tacrolimus or cyclosporin also becomes one of those kind of drugs. Somebody is also raised about angiotensin receptor blockers being equal. I usually choose a long-acting angiotensin receptor blocker, which can be used once a day. Telmisartan or olmesartan are long-term, long-active drugs, so once a day dosage is possible. I will optimize the dose by titrating it to the blood pressure and tolerability of the people and try to reduce albuminuria or proteinuria as much and go higher doses of telmisartan or angiotensin receptors. Angiotensin receptors versus ACE, that's also one of the questions. I think angiotensin receptors are preferred these days. They are cost-wise, they are now become cheaper. So I wouldn't say that cost is. So I would choose angiotensin because ACE in about 30% gives cough. So I would feel that angiotensin receptor blockers probably would be better. In my clinical practice, I use angiotensin receptor blockers wherever it is possible. If they don't tolerate, then I change to ACE inhibitor. But they're equally good.
Thank you, sir, for excellent discussion. And I think we will conclude the session with this excellent discussion. I thank you, Dr. Kher, sir, Dr. Misra, sir, and all the participants. They spent their time on this Sunday. And again, I thank you all for this wonderful session. Thank you.
Thank you. Thank you,
Thank you,
Banwari,
sir.
for this. Thank you, everyone.
Thank you, sir.
It was a good opportunity for me to
Yes,
see Dr.
and me
Dr.
also.
Misra.
I could remember hundreds of patients discussing with you all lupus nephritis, and
Yes.
at the corridor in your room with a cup of coffee. Now we can discuss without a cup of coffee.
That's true. Thank you. Thank you very much. Pleasure.
Thank you.